Hello there. We'll be continuing with few more scenarios in the critical care. Let's begin. Okay, here is a case of a 40-year-old woman who presents to the emergency department with a severe diffuse chest pain, which began 6 hours ago. She developed non-productive cough over past 3 days and has been unwell, and there is shortness of breath. She has a medical history of sickle cell anemia, receives frequent blood transfusion, the most recent being 3 weeks. On examination, her heart rate is 130, blood pressure is 96/64, body temperature is 39 degrees Celsius. IV fluids along with supplemental oxygen are ongoing. So, in this case, what is being asked is the next appropriate step in the management. So, as it seems, according to the history of the patient, this won't be. So, according to the history of the patient is having sickle cell anemia, has a history of sickle cell anemia, so which is quite relevant. It is pointing towards acute chest syndrome. So that is what we are dealing with here in this case. That is acute chest syndrome. Acute chest syndrome is a serious complication of sickle cell disease, and it is a spectrum ranging from simple pneumonic illness to acute respiratory distress syndrome. It is a serious complication of sickle cell disease, and it ranges from simple pneumonic illness to acute respiratory distress syndrome. It is a vaso-occlusive crisis of lungs and includes pulmonary infiltrates on the chest X-ray along with fever, pain, and respiratory symptoms. So there is vaso-occlusive crisis of the lungs and it includes pulmonary infiltrates on chest X-ray plus fever, chest pain, and respiratory symptoms. In this, due to the chest pain, patient will be having restricted ventilation. So, in acute chest syndrome, the patients will have restricted ventilation due to the chest pain. So, due to chest pain, uh, it will lead to reduced ventilation or restricted ventilation. Therefore, effective analgesia will relieve the pain and allow for deeper breathing, and thereby improving the oxygenation in the process, and hence improving improving the oxygenation in the process. So this is briefly about acute chest syndrome, ACS. It is a serious complication of sickle cell disease, and it is ranging from simple pneumonic illness to acute respiratory distress syndrome. In this, there is vaso-occlusive crisis of lungs and includes pulmonary infiltrates appearing on the chest X-ray associated with fever, pain, chest pain, and respiratory symptoms. Patient will have reduced or restricted ventilation due to the chest pain. Therefore, effective analgesia will help in relieving the pain and thereby improving the ventilation, allowing for deeper breathing and improving the oxygenation. Finally, so So in this case, because as we studied, analgesia is very important so as to relieve the chest pain, to improve ventilation and thereby the oxygenation of the patient. Therefore, analgesia will help us in going towards morphine as the answer. So, morphine, which is a strong opiate used in the treatment of moderate to severe pain, that will be used here. So, strong opiate. It is rarely given enterally due to low oral bioavailability. Side effects are like sedation, respiratory depression, and constipation. Salbutamol is a short acting beta 2 agonist which is given by inhalation to treat asthma and other conditions. It won't be the answer here. Salbutamol is a bronchodilator. It So here other options that we can have uh, can be salbutamol, hydrocortisone, blood transfusion, hydroxycarbamide. But the best or next appropriate step in the management would be morphine, that is analgesia. Hydroxycarbamide decreases the frequency of vaso-occlusive pain crisis by increasing fetal hemoglobin. Usually it is given if there are recurrent crises, exchange transfusion in severe life-threatening manifestations. Now let's move on to the next scenario. Before we move further, I can I think I should refer a little more about acute chest syndrome. It is an important complication of sickle cell disease characterized by fever, respiratory symptoms, and a new pulmonary infiltrate on chest x ray. Uh, Patients should be monitored for this complication throughout their hospital stay, and all hospitals should have a treatment pathway for care. Essential investigations for diagnosis and prognosis include chest x ray, full blood count, basic biochemistry tests. ABG analysis should be considered in adults with low oxygen saturation, as severe hypoxia is a useful predictor of severity and helps in guiding the treatment. So, investigations, may we can have chest x-ray, and we can have full blood count and biochemistry tests, then ABG analysis. And ABG is a useful predictor of severity. Etiology is multifactorial. It includes infections, so careful investigation for infective causes should be undertaken, including blood culture, sputum for microscopy, culture and sputum, and nasopharyngeal aspiration for viral testing. So, blood culture, sputum, culture, and microscopy, and sputum and nasopharyngeal aspiration for viral testing. Nasopharyngeal aspirate and sputum for viral testing. Basic management will include prompt pain relief, incentive spirometry, treatment of bacterial or viral infection. Blood transfusion should be considered early in the hypoxic patient. A simple top-up transfusion may help in early or less severe disease, but exchange transfusion will be necessary if there are features of clinical severity or a lack of response to simple transfusion. So, management will involve prompt pain relief or prompt analgesia, as we studied, and along with that, incentive spirometry and treatment of infection, that is antibiotic coverage. Usually exchange transfusion is considered. A top-up transfusion may help in a less severe case, but exchange transfusion will be necessary if there are features of severity or lack of response to simple transfusion. The critical care team should be involved in the care of any patients with severe clinical features or in a deteriorating patient to consider non-invasive or invasive ventilation. Following an episode of acute chest syndrome, the patient should be offered disease modifying therapy, that is, hydroxycarbamide and blood transfusion. Okay, so following an episode of acute chest syndrome, the patient should be offered certain disease modifying therapies, such as hydroxycarbamide and blood transfusion. So, hydroxycarbamide is also considered. Following ACS episode, hydroxycarbamide and transfusion should be provided to the patient. This is disease modifying therapy. Disease modifying therapy. I think now this is sufficient for acute chest syndrome. Let's move to the next scenario. Let me just go through the scenario first. So the scenario is here's a case of 28-year-old man who is brought by the paramedics to the emergency department with a decreased level of consciousness. He was found by his friend in his house unconscious with MDMA pills in his pocket. His limbs are rigid, pupils dilated, he is agitated and sweating. Heart rate is 105, respiratory rate is 22, blood pressure is 140/70, temperature is 40.8 degrees Celsius. His blood results show a venous lactate of 4.1. He is mechanically ventilated. What is the single most appropriate medication to administer to this patient in this case? That is what is being asked. So, in this case, which is a case of drug induced hypothermia, dantrolene seems to be the best answer, which is used to manage drug induced hypothermia, especially where there is muscular hyperactivity. Dantrolene intravenously is given in patients with MDMA overdose where their temperature is above 40 degrees Celsius. So, this is a case of drug induced hypothermia. Patient is clearly having his body temperature on a higher side, that is 40.8 degrees Celsius, and there is a history of intake of pills, MDMA pills. So this is clearly a case of drug induced hypothermia. And in this case, dantrolene is used for the management. Dantrolene is given in patients with MDMA overdose where body temperature body temperature is above 40 degrees Celsius. MDMA is 3,4 methylene dioxy and methylamphetamine. So dantrolene is given in MDMA overdose cases where body temperature is more than 40 degrees Celsius. It is used to manage drug-induced hypothermia, especially if there is muscular hyperactivity. Certain other confusing options can be given in the question like baclofen, procyclidine, baclofen being an antispasmodic which is often used in muscular spasms, and procyclidine which is an antimuscarinic drug used for the treatment of drug-induced Parkinsonism. So in this we will give dantrolene, but baclofen and procyclidine. Baclofen which is an antispasmodic used in muscle spasms in palliative care. Procyclidine which is an antimuscarinic drug. It is used in case of drug-induced Parkinsonism. Akathisia and acute dystonia. Certain other differential diagnosis of this case can be NMS, that is neuroleptic malignant syndrome. Because hypothermia can be due to different causes. There can be malignant hypothermia, which is mainly genetic and caused by even certain anesthetic agents. Or there can be serotonin syndrome, which is a side effect of SSRIs or SNRIs, and neuroleptic malignant syndrome, which is caused by antidopaminergic medications like antipsychotics, metoclopramide. MDMA is a dopamine inducer. MDMA is dopamine inducer. MDMA is a dopamine inducer. So basically, whenever there is hypothermia, drug-induced hypothermia associated with increased muscular activity, or there is rigidity, always dantrolene is given. So it is given in MDMA overdose cases with body temperature more than 40 degrees Celsius. Now we have to, I think here what's another thing which is important is MDMA or ecstasy overdose. Let's study a little more about this MDMA drug. The drug is popularly associated with rave parties, concerts, and it is a combination of drug induced euphoria and high energy which contribute to growing numbers of emergency department visits following these events. This drug is commonly called as ecstasy or molly, which is a popular name. Ecstasy or molly, which is a popular club drug. So, commonly used at bars and parties, these club drugs are popular among teenagers and young adults. This MDMA, which is a synthetic amphetamine drug, also known as ecstasy or molly, is a popular club drug. It has both stimulant and hallucinogenic effects. It enhances the tactile sensations while producing feeling of increased energy and euphoria. For some people, it may also distort the perception of time, enhances the feeling of empathy, stimulate sexual arousal. So these are certain effects of this drug. It has both stimulant and hallucinogenic effects. Enhances tactile sensations with increased energy and euphoria. Now, signs and symptoms of MDMA overdose. Uncontrolled body movements, confusion or altered mental status, anxiety, restlessness, or even paranoia. Headache and blurred vision, clenched jaws, increased body temperature, chills, and excessive sweating, abdominal cramps, nausea, vomiting, irregular and rapid heart rate, increased blood pressure, urinary retention, and delayed orgasm. Certain other symptoms can be like fainting. I mean, if it is more serious, then we will have these symptoms: fainting, or rather say fainting spells, loss of consciousness, seizures, panic attack. These can also happen. Very high blood pressure and very high body temperature are other things which indicate severity. The one is muscle twitching. It's also important. Treatment would be detoxification, individual counseling, and group therapy. These would be the treatment which we can offer to this patient. Let's uh, go through it again once quickly. So, this is a case of MDMA overdosing. MDMA being a club drug, MDMA is also called as ecstasy or Molly. In common language, it is a club drug. It has both stimulant and hallucinogenic effects. Now, this MDMA overdose can cause hypothermia. In case of drug induced hypothermia, dantrolene is used for the management, especially when this drug induced hypothermia is associated with rigidity or features like muscular hyperactivity. So, whenever there is a case of MDMA overdosing associated with increased body temperature, that is, body temperature more than 40 degrees Celsius, dantrolene is always considered in such cases. MDMA overdosing plus body temperature more than 40 degrees Celsius. Other than that, certain signs and symptoms of MDMA overdosing will be uncontrolled body movements or muscle twitching, confusion, altered mental status, anxiety, restlessness, paranoia, headache, blurred vision, clenched jaws, increased body temperature, that is, sharp rise in body temperature, along with chills and excessive sweating, uh, increased blood pressure, nausea, vomiting, abdominal cramps, irregular and increased heart rate, that is, palpitations, will be there, urinary retention, delayed orgasms. There can be loss of consciousness, seizures, panic attack, fainting spells, etc. So, dantrolene intravenously is given in patients with MDMA overdose where their temperature is above 40 degrees Celsius. This is important. There was agitation, dilated pupils, rigidity in the limbs. For agitation, we can give diazepam. Sweating is there, dehydration, metabolic acidosis, heart rate is increased, tachypnea is there, hypothermia is there. Okay, let's move on to the next scenario. So here we have a 63-year-old man who underwent an open aortic valve replacement surgery. A few hours later in the recovery room, his blood pressure suddenly drops to 77/30. His blood pressure an hour after the operation was 120/70. Currently, he has a pulse rate of 120 beats per minute and has cardiac output of 3 liters per minute. His pulmonary capillary wedge pressure is 22. So this is the scenario. So here we have a case of cardiogenic shock. Let's first draw an important table regarding different types of shock. rate, cardiac output, and pulmonary capillary wedge pressure. Hypovolemic shock. In hypovolemic shock, heart rate will increase, cardiac output will be variable, pulmonary capillary wedge pressure will decrease. In cardiogenic shock, heart rate will increase, cardiac output will decrease, PCWP will increase. Cardiogenic shock is the only type of shock in which pulmonary capillary wedge pressure will increase. Septic shock. Heart rate will increase. Cardiac output, first it will increase, then it will decrease. Early stage, it will increase, and late cardiac output will decrease. PCWP will decrease. Neurogenic shock. In this, the heart rate will decrease. Neurogenic shock is the only type of shock in which heart rate will decrease. Cardiac output will decrease. PCWP will also decrease. Anaphylactic shock. In this, heart rate will increase. Cardiac output will decrease, and pulmonary capillary wedge pressure will also decrease. So this is a small table which we should remember. In almost all the types of shock, except neurogenic shock, heart rate will increase. For compensation, heart rate will increase. So, except neurogenic shock, in all the types of shock, heart rate will increase. And pulmonary capillary wedge pressure, in all the types of shock, pulmonary capillary wedge pressure will decrease. It will always decrease, except cardiogenic shock, where it will increase. Pulmonary capillary wedge pressure will increase only in cardiogenic shock. That is important. Cardiac output, in case of hypovolemic, it will be variable. In case of cardiogenic, it will decrease. Neurogenic, it will decrease. Anaphylactic, it will decrease. Septic, in early stage, it will increase. Later stage, it will decrease. More or less, it usually decreases, except it being variable in case of hypovolemic shock, and in septic shock, in the early stage, it increases and decreases in the later stage. And neurogenic shock is the only type of shock in which heart rate will decrease. And cardiogenic shock is the only type of shock in which pulmonary capillary wedge pressure will increase. These are the two important things. Now, PCWP. That's pulmonary capillary Wedge pressure. Pulmonary capillary wedge pressure is measured by inserting a Swan-Ganz catheter into a peripheral vein like jugular femoral and advancing the catheter through right atrium and right ventricle and until a branch of pulmonary artery is reached. The balloon is then inflated and pressure is recorded, which is an indirect estimate of the left atrial pressure. Balloon is then inflated and pressure is recorded, which is an indirect estimate of the left atrial pressure. Normal pulmonary capillary wedge pressure is 6 to 12 mm Hg. 6 to 12 mm of Hg is the normal capillary wedge pressure. In case of cardiogenic shock, PCWP is more than 18 mm Hg. Increased pulmonary capillary wedge pressure is seen in left-sided heart valvular problems like mitral regurgitation or mitral stenosis and aortic regurgitation or aortic stenosis. Increase in pulmonary vascular resistance will cause increase in pulmonary capillary wedge pressure. So this is about pulmonary capillary wedge pressure, which is measured by inserting a Swan-Ganz catheter into a peripheral vein like jugular vein or femoral vein, then advancing that catheter through the right atrium, right ventricle, until a branch of pulmonary artery is reached. Then the balloon on that catheter is inflated and the pressure is recorded, which is an indirect estimate of the left atrial pressure. Normal pulmonary capillary wedge pressure is Normal pulmonary capillary wedge pressure is between 6 to 12 mmHg. Only in cardiogenic shock, pulmonary capillary wedge pressure increases. Cardiogenic shock is the only type of shock in which PCWP will increase. It will become more than 18 mmHg. And this pulmonary capillary wedge pressure increases in case of left-sided heart valvular problems such as mitral regurgitation, mitral stenosis, and aortic regurgitation and aortic stenosis. And increased pulmonary vascular resistance will cause increased pulmonary capillary wedge pressure. So it is helpful to differentiate the type of shock that the person is having, since only cardiogenic shock will cause increased pulmonary capillary wedge pressure by increasing the pulmonary vascular resistance. And heart rate will always increase in all the types of shock except neurogenic shock, in which it will decrease. Pulmonary capillary wedge pressure will always decrease in all the types of shock except cardiogenic shock, in which it will increase more than 18 mmHg. Cardiac output, it will be variable in case of hypovolemic shock. In case of cardiogenic shock, it will decrease. Neurogenic shock, it will decrease. Anaphylactic shock, it will decrease. Septic shock, it is a little more complicated. In the early stage, it will increase. In the later stage, it will decrease. That is all about this. Now let's move further to next scenario. Now, cardiogenic shock is a condition where there is inadequate blood flow due to the dysfunction of the ventricles of the heart, resulting in hypotension. And neurogenic shock occurs from a consequence of a spinal cord injury, which leads to autonomic instability, which is manifested in the form of hypotension, bradyarrhythmia, and temperature dysregulation. So basically, neurogenic shock, the origin is from the nervous system, as the name itself tells. So it occurs from a consequence of a spinal cord injury, which leads to autonomic instability, which is manifested in the form of hypotension, bradyarrhythmia, and temperature dysregulation. Whereas in cardiogenic shock, there will be inadequate blood supply or inadequate blood flow due to dysfunction of the ventricles of the heart, resulting in hypotension. Anaphylactic shock is a cardiovascular collapse which is associated with an anaphylactic reaction. The reaction results in systemic vasodilation, which results in hypotension 30% lower than individual's baseline. An intravascular volume can also decrease due to inflammatory mediators, making the vasculature more leaky. So, anaphylactic shock is basically shock which occurs as a result of anaphylaxis. It is cardiovascular collapse which is associated with that anaphylactic reaction. The reaction causes systemic vasodilation, which results in hypotension, and it is around 30% lower than the baseline. Intravascular volume can further also decrease due to increase in the inflammatory mediators, which make the vasculature more leaky. So that is about this. Anyway, let's move to the next scenario. Okay, so here we have a case of a 21-year-old man who is brought to the emergency department due to dyspnea. In a broken sentence, he states that he has been trying to control his asthma using his puffers without any success. He appears to be in mild distress with supraclavicular retractions. His lips and fingernails have a blue tinge. Senior help is sought, and appropriate nebulizers, oxygen, and intravenous corticosteroids have been administered. Local anesthetic is applied, and a sample is taken for arterial blood gas an hour after active management. Investigations show pH is 7.2, PaO2 is 10, PaCO2 is 6.3, base excess is -4. So, what is being asked here is the next most appropriate management. As patient here is in respiratory acidosis, so we should admit the patient to intensive care unit. That should be the next most appropriate management in this case, because the asthma is not responding to the medical management, and even the pH is 7.2. Normal range is 7.35 to 7.45. Basically it's around 7.4 is normal, so pH is also less than normal, that is towards acidosis, 7.2. Also having history of asthma which is not responding to medication, already having bluish tinge on lips and fingernails. So this patient needs to be admitted to intensive care unit. And this is a case of respiratory acidosis. Basically what we have to focus is that respiratory acidosis in context of asthma exacerbation needs to be taken seriously. And admitted to the intensive care unit where intubation can be done if necessary. If required. Increased PSO2 suggests imminent respiratory arrest and considered near fatal attack. A rise in PSO2. It will suggest imminent respiratory arrest and is considered a near fatal attack. In general, life threatening asthma usually begins with respiratory alkalosis due to tachypnea. In general, life threatening asthma attacks usually begin with respiratory alkalosis due to tachypnea. Respiratory alkalosis is the most common initial acid base balance with life threatening asthma. As the asthma attack worsens, PaCO2 would rise and ultimately acidosis develops. So, life threatening asthma attack usually begin with respiratory alkalosis, which is caused due to tachypnea. That is, there is more washout of CO2 due to tachypnea. So it leads to respiratory alkalosis. So this is the most common initial acid base balance with life threatening asthma. Now, as the asthma attack worsens, PaCO2 would increase and ultimately respiratory acidosis develops. Patient presenting with cyanosis is a sign of life-threatening asthma. And immediate management is carried out. Immediate management is done in the emergency department itself, where high flow oxygen is given Nebulization with salbutamol is done, and nebulization with salbutamol and ipratropium, and intravenously corticosteroids can be given like hydrocortisone. Intravenously hydrocortisone is given. Refer any patient to intensive care unit with life-threatening asthma failing to respond to therapy evidenced by low pH on arterial blood gas. Very, very important. Refer any patient to ICU with life-threatening asthma failing to respond to therapy evidenced by low pH on ABG. So any patient who is having life-threatening asthma who is not responding to the therapy, which can be shown by low pH on ABG, that they are developing respiratory acidosis and their asthma, life-threatening asthma, is not responding to medication, such patient should always be referred to intensive care unit, that is ICU. So here main thing is life-threatening asthma and its acute exacerbation. So respiratory acidosis, because we already know in life-threatening asthma, initially respiratory alkalosis occurs due to tachypnea. It is only later on when PaCO2 rises and ultimately leads to respiratory acidosis. So when the patient is already having respiratory acidosis, that means it is always late. So respiratory acidosis in context of asthma exacerbation needs to be taken seriously, and the patient should be admitted to ICU where intubation can be done if required. Increased PaCO2 suggests imminent respiratory arrest and considered near fatal attack. Near fatal attack. Okay. And life-threatening asthma attacks usually begin with respiratory alkalosis, which occurs due to tachypnea, which is the most common initial acid-base balance with life-threatening asthma. As the asthma attack further worsens or exacerbates, PaCO2 rises and ultimately respiratory acidosis develops. Patient presenting with cyanosis is a sign of life-threatening asthma. Immediate management should be done in the emergency department itself. And this immediate management includes high flow oxygen therapy, nebulization with salbutamol and ipratropium, intravenous corticosteroids such as hydrocortisone. So we have to refer any patient to ICU with life-threatening asthma failing to respond to therapy evidenced by low pH on ABG. That is it about this. Now let's move to the next scenario. Let's take a break for a while. and I'll be back. So let's now go on to the next scenario. Here we have a 77 years old man who was admitted to the hospital following a week-long history of shortness of breath, cough, and fever. His medical history includes having pulmonary embolism 2 years ago, myocardial infarction when he was 69 years old, and COPD diagnosed when he was 60 years old. He has been on immunosuppressive drugs following renal transplantation around 20 years ago. A chest x ray performed as an inpatient shows multiple patchy opacities. He was subsequently started on intravenous antibiotics. His observations continued to deteriorate. He became less responsive and hypotensive over the next day. 2 days following admission to intensive care unit, he dies. So, in this question, what is being asked is regarding the death certificate of the patient. So, the most appropriate condition to be filled in part 1A of the death certificate of this patient would be pneumonia. This patient presented to the hospital with a week long history of shortness of breath with cough and fever. So the patient presented with pneumonia itself to the hospital and he was treated for pneumonia, but the patient continued to deteriorate and died. So, in deaths directly related to infectious disease, one should always write the manifestation in part 1A, not something like chest infection because it is too vague. Because chest infection can not only mean pneumonia, it can also mean an infection of the skin of the chest. Immunosuppression, as the patient was on immunosuppressive agents, immunosuppression can be put in the death certificate, but it can be put as part 1B as it is considered as causative factor or it is considered a condition which is leading to 1A. Immunosuppression has led to pneumonia. So it can be included in part 1B. Apart from that, apart from this chronic obstructive airway diseases, there is COPDs and ischemic heart disease could be written in part 2 as these are other significant conditions which contributed to the death, but these are not directly related to the disease or condition causing it. So this is regarding the death certificate. In death certificate 1A, 1B, and 1C. 1A will include the immediate cause. 1B will include antecedent cause. 1C will include underlying cause. So in part 1A, in deaths which are directly related to infectious disease, one should write the manifestation in part 1A. Manifestation in infectious diseases. In part 1B, we can write a condition leading to 1A. That is in this case immunosuppression. In this case, in 1A, we will write pneumonia. That is the immediate cause of the death of the patient. That is how this disease manifested, and that is the immediate cause of the death. And patient also presented with pneumonia to the hospital. 1B will be the contributing factor, antecedent cause, or these are the conditions which are leading to 1A. So 1B will include immunosuppression because the patient is on immunosuppressive agents following renal transplantation. So it has made the patient more vulnerable, and it has kind of contributed, and it is a condition which has led to 1A. So in 1B, we will write immunosuppression. Whereas other conditions like chronic obstructive pulmonary disease, COPDs, and ischemic heart disease, patient has MI, so we can write ischemic heart disease and COPD in part 2 because these are other significant conditions contributing to the death. Other significant conditions contributing to the death but not related to the disease or condition causing it. It is not directly related with the disease or the condition which is causing death of the patient, but it is contributing to the death. So doctors are expected to state the cause of the death to the best of their knowledge and belief. Even without changes to the law, there is increased scrutiny of death certification and patterns of mortality by various agencies. So we should not give inadequate or vague causes of death. For example, if a patient dies under care of an orthopedic surgeon, it might be expected that some orthopedic condition contributed to the death. So this condition would be mentioned in part 1 and part 2 of the certificate. Similarly, it would be surprising if a patient was being treated in an acute hospital but no significant disease or injury at all was mentioned on their certificate. Sequence leading to death, underlying cause, contributory causes. WHO defines the underlying cause of death. Okay, part 1 is underlying cause of death. So, according to WHO, part 1A is the disease or injury which initiated the train of morbid events leading directly to death. Part 1A will include the disease or injury which initiated the train of morbid events leading directly to death. Part 1B will include circumstances of the accident or violence which produced the fatal injury. Part 1A, disease or condition directly leading to death. Part 1B, other diseases or conditions which are leading to 1A. Part 1C, these are other diseases or conditions or underlying causes. Part 2, other significant conditions contributing to death but not related to the disease or condition causing it. For example, cerebral infarction would be in 1A. Thrombosis of basilar artery would be in 1B. Cerebrovascular atherosclerosis would be in 1C. So 1C will lead to 1B, 1B will lead to 1A. Hmm. More than one disease may have led to the death. So there can be joint causes of death. Like 1A, hepatic failure has occurred. Hepatic failure occurred due to liver cirrhosis. 1B, liver cirrhosis occurred due to chronic hepatitis C infection and alcoholism, which are the joint causes of death. So ischemic heart disease and chronic obstructive airway disease both can be put together. Joint causes can be put together as well, which have both resulted in cardiorespiratory failure. 1A, cardiorespiratory failure caused due to ischemic heart disease and chronic obstructive airway disease. Old age or senility or frailty of old age should only be given as a sole cause of death in very limited circumstances, usually avoided. Old age or senility, usually avoided. As the sole cause. of death. Organ failure, same thing. Usually avoided being used alone. For example, renal failure has to be followed with something like necrotizing proliferative nephropathy. It has to be followed with something like SLE. In the same way, liver failure has to be followed by something like hepatocellular carcinoma, which can be caused due to chronic hepatitis B infection, which has led to that. So they should never be used alone. Natural conditions, organ failure, old age, senility. Avoid modes of dying. Modes of dying are avoided, like cardiac or respiratory arrest, syncope, shock. Abbreviations or symbols are never used. Specify the specific causes of death. Try to be specific and technical, not vague. So in this case, to be filled in 1A, we should go with pneumonia, not cardiac arrest, not embolism, not immunocompromised status, not chest infection. It is pneumonia, which is the disease or injury which is directly leading to death. Let's move to the next scenario. Now here we have a 67-year-old man who has been feeling chest discomfort and dizziness that started a few hours ago. He has had diarrhea over the past 4 days. He started perindopril 2 weeks ago. He has temperature of 37.1 degrees Celsius, blood pressure 101/68, respiratory rate 15, heart rate is 40. ECG performed in emergency department shows widening of QRS complex. Okay. Blood results are sodium is 139, potassium is 7, urea is 6, creatinine is 220, GFR is 30. Okay, so this is the scenario. Let me just go through the scenario once. Now, in this scenario, what is being asked is the single most appropriate management. As we are seeing, the patient is having widened QRS complexes, and the potassium level is 7, and the normal potassium level is 3.5 to 5. Normal sodium level is 135 to 145. So clearly, the patient is having severe hyperkalemia because potassium level is more than 6.5, and there are even ECG changes. There is widening of QRS complex. Therefore, we have to take steps to resolve this hyperkalemia. So, intravenous calcium gluconate has to be given. Blood results show severe hyperkalemia, more than 6.5, and it has directly likely resulted from dehydration due to the diarrhea and starting an AC inhibitor, perindopril. ECG changes are consistent with hyperkalemia, which are always alarming. The need for urgent intravenous calcium gluconate is a life saving step, as this patient could have cardiac arrest. Administration of calcium will also stabilize the myocardium and resolve the bradycardia. Atropine is used for symptomatic bradycardia, but it is ineffective in most cases of bradycardia caused by hyperkalemia. Transcutaneous pacing is also ineffective in hyperkalemia. So, atropine is used for symptomatic bradycardia, but in case of bradycardia which is caused by hyperkalemia, we don't give atropine. In this case, we give calcium gluconate because calcium will not only help in stabilizing the myocardium, it will also resolve bradycardia caused by hyperkalemia. In case of symptomatic bradycardia, atropine can be given though. But in case of hyperkalemia induced bradycardia, atropine will be ineffective. Transcutaneous pacing is also ineffective in hyperkalemia. The management should be concentrated on resolving the electrolyte problem, firstly by giving intravenous calcium to stabilize the cardiac membrane, followed by intravenous insulin and glucose to shift the potassium from extracellular to intracellular fluid compartment. we have a case of hyperkalemia. So in this, what we have to focus on is that if ECG changes are consistent with hyperkalemia, then it is always alarming. Urgent IV calcium gluconate is life saving because patient can have a cardiac arrest. Calcium will also help in stabilizing the myocardium and resolving the bradycardia caused by hyperkalemia. So management is focused on resolving electrolyte problem, electrolyte issue. Firstly, by giving IV calcium gluconate to stabilize the cardiac membrane. Second, IV insulin and glucose shift, because when insulin is given intravenously, it will cause shifting of potassium from extracellular, from ECF to ICF, intracellular compartment. Therefore, the potassium level in the blood, in the extracellular fluid, will decrease. These are the steps. Atropine is used for symptomatic bradycardia but it is ineffective in bradycardia caused by hyperkalemia. Transcutaneous pacing is also ineffective in hyperkalemia. So these are the few things which we have to take care in hyperkalemia. First thing is that if hyperkalemia has already caused ECG changes, then it is an alarming situation. Always, it is an alarming situation if ECG changes are consistent with hyperkalemia, such as widening of QRS complex here in this case. Therefore, in this case, urgent intravenous calcium gluconate has to be given, which is a life-saving procedure, life-saving step, because this patient can have a cardiac arrest. This calcium will help in stabilizing the myocardium, and it will also help in resolving the bradycardia caused by hyperkalemia. Now, the steps in the management of hyperkalemia are mainly focused on resolving the electrolyte issue first. That is, first we will give intravenous calcium gluconate to stabilize the myocardium or cardiac membrane and resolve the bradycardia caused by hyperkalemia. Then we will give intravenous insulin and glucose, which will cause shifting of potassium from extracellular to intracellular compartment. Atropine can be used in systemic bradycardia, but atropine is ineffective. Atropine can be used for symptomatic bradycardia, but it is ineffective in bradycardia caused by hyperkalemia. And transcutaneous pacing is also ineffective in bradycardia caused by hyperkalemia. Atropine is an anticholinergic drug which works to counteract the effect of parasympathetic activation and has multiple application. Counteract effects of parasympathetic nervous system activation. It can be used in eye drops for cycloplagia and anterior uveitis. It can be used intravenously to treat poisoning with insecticides or nerve agents. It can also be used to counteract intraoperative or post-MI bradycardia. So uses of atropine are in eye drops for cycloplagia and uveitis. Second, it is used in insecticide poisoning. And it is used in case of intra-op or post MI bradycardia. So these are the three uses of atropine. Atropine, which is an anticholinergic drug, it counteracts the parasympathetic activation. That means its effects are like sympathetic nervous system. It is used for symptomatic bradycardia, but it is not effective in bradycardia induced by hyperkalemia. It is used in eye drops for cycloplegia and anterior uveitis. It is used for insecticide poisoning. It is also used in intra-op or post-MI bradycardia. And one more important thing is that intramuscular adrenaline is gold standard treatment for anaphylaxis. Intramuscular adrenaline is the gold standard treatment for anaphylaxis. Now let's move on to another scenario. Here we have a 55-year-old man with pre-existing triple vessel disease has a sudden onset of chest pain that started 4 hours ago. He's having shortness of breath, sweaty, feeling dizzy. His blood pressure is 140/80. Blood results show hemoglobin of 63, where normal is 130 to 180. And his ECG is given. Let me just go through the scenario once. Now, in this case, there is widespread ST depression. There is widespread ST depression, especially in lead 1 to V2 to V6, along with ST elevation in AVR. The combination of widespread ST depression plus symptoms of myocardial ischemia, along with ST elevation in AVR for more than 1 mm, indicate either LAD occlusion, LMCA occlusion, severe triple vessel disease. Patient already has a history of pre-existing triple vessel disease which explain the ECG findings here. The man is suffering from type 2 acute coronary syndrome, secondary to anemia and pre-existing triple vessel disease. Type 2 means that the ischemia is due to either increased oxygen demand or decreased supply. In this case, it is both. So in this case, we will give dual antiplatelet therapy, fondaparinux, and blood transfusion. Fondaparinux activates antithrombin 3, which inhibits coagulation factors 10A. It is used in acute coronary syndrome. Clopidogrel and aspirin are used to prevent myocardial infarction in future. Antiplatelet therapy, clopidogrel and aspirin. Since hemoglobin is below 80, the patient is symptomatic, transfusion would be of great benefit. So here we are dealing with the case of triple vessel disease. So if there is widespread ST depression, this is an extra point. If there is widespread ST depression plus symptoms of myocardial ischemia, with ST elevation in AVR for more than 1 mm, it indicates either LAD occlusion, LMCA occlusion, severe triple vessel disease. patient already has a history of pre-existing triple vessel disease, which explain the ECG findings. So the man is suffering from type 2 acute coronary syndrome secondary to anemia and pre-existing triple vessel disease. Type 2 means the ischemia is caused either due to increased oxygen demand or decreased supply. So in this we will give dual anti-platelet therapy, aspirin plus clopidogrel to prevent MI in future, plus fondaparinux activates antithrombin 3 which inhibits coagulation factors 10A used in acute coronary syndrome, plus blood transfusion as patient is symptomatic and hemoglobin is less than 80 grams per liter. Here the patient is having type 2 acute coronary syndrome secondary to anemia and triple vessel disease. Percutaneous coronary intervention. It is a non-surgical procedure which utilizes a catheter to restore the flow in coronary circulation in the treatment of obstructive coronary vascular disease. Percutaneous coronary intervention is indicated in the management of myocardial infarction if it is done within 120 minutes of the onset of symptoms. PCI works to dilate the coronary arteries from within utilizing a balloon catheter, which is then often followed by the placement of a metallic stent to maintain the patency of the vessel. PCI is suitable for those with single vessel disease or preserved left ventricular function post-MI. Alteplase is a human tissue plasminogen activator which binds to fibrin in a thrombus, allowing the conversion of plasminogen to plasmin. Plasmin then degrades the fibrin into soluble fibrin to allow dissolution of thrombus, exerting its thrombolytic action. Alteplase is used as thrombolytic agent in ischemic stroke. Okay, so there are two other extra things here. One is percutaneous coronary intervention. It is a non-surgical procedure where catheter is used to restore flow in the coronary circulation and treatment of obstructive coronary vascular diseases. PCI is indicated in MI if it's done within if it is done within 120 minutes of onset of symptoms. It involves dilating coronary arteries from within using balloon catheter, which is followed by placement of a stent. Metallic stent. To maintain the patency. PCI is suitable for patients with single vessel disease and preserved left ventricular function post MI. So this is regarding percutaneous coronary intervention. So let's just go through this thing once again in brief. First is as we went through that case of triple vessel disease, there were in ECG there were widespread ST depression. Along with that, there were symptoms of myocardial ischemia with ST elevation in AVR. So there were widespread ST depression in all the leads, and along with that, there were symptoms of myocardial ischemia like shortness of breath, sweating, feeling dizzy, and along with that, there was ST elevation in AVR. So it indicates either LED occlusion, LMC occlusion, or severe triple vessel disease. This patient was having type 2 acute coronary syndrome secondary to anemia. Hemoglobin was also less with triple vessel disease. So we will give dual antiplatelet therapy, that is aspirin plus clopidogrel, to prevent future MI, myocardial infarction, plus fondaparinux. Fondaparinux inhibits antithromb fondaparinux activates antithrombin 3, which inhibits coagulation factor 10A. So it is used in acute coronary syndrome. Along with that, because hemoglobin is less and the patient is symptomatic, we will also carry out blood transfusion. Now, percutaneous coronary intervention. It is a non-surgical procedure where catheter is used to restore the flow in the coronary circulation in treatment of obstructive coronary vascular diseases. It is indicated in MI or myocardial infarction if it is done within 120 minutes of onset of symptoms. It involves dilating the coronary arteries from within using a balloon catheter, which is followed by placement of a metallic stent so as to maintain the patency of the vessel. Percutaneous coronary intervention is suitable for a patient with single vessel disease and preserved left ventricular function post MI. The thing which is an extra point is alteplase. Alteplase is a human tissue plasminogen activator. It binds to fibrin in a thrombus and allows conversion of plasminogen to plasmin. Plasmin then degrades fibrin into soluble fibrin, which causes dissolution of thrombus. Exerting the thrombolytic action. Alteplase is used as a thrombolytic agent in ischemic stroke. So this is regarding alteplase. Alteplase is a human tissue plasminogen activator. It binds to fibrin in a thrombus and allows conversion of plasminogen to plasmin. Plasmin then further degrades the fibrin into soluble fibrin, which causes dissolution of thrombus or breaking of thrombus, carrying out the thrombolytic action of alteplase. Alteplase is used as a thrombolytic agent in ischemic strokes. In case of ischemic stroke. Triple vessel disease will involve left anterior descending artery, left circumflex artery, right coronary artery. Okay, let's move on to another scenario. Here we have a 68 years old man who had undergone an elective transurethral resection of prostate few hours ago. Following the procedure, he starts to become confused, has a seizure. Medical history includes type 2 diabetes. His blood results are sodium is 119, a little low. Normal is 135 to 145. Potassium is 6.1. Normal is 3.5 to 5. Urea is 5. Creatinine is 85. GFR is 90. More than 90. Glucose is 7 millimoles per liter. Intravenous 3% sodium chloride was administered. A 12 lead ECG was performed, which shows sinus rhythm without hyperkalemic changes. So, this is the scenario. Let me just go through it once again. Now, this question is a little tricky because in this case there are two conditions. One is hyperkalemia, another is hyponatremia. Patient has moderate hyperkalemia without any ECG changes. The guidelines among the trusts differ, but since there is no consensus in using intravenous calcium to treat the moderate hyperkalemia without ECG changes, the best answer here would be intravenous sodium chloride. The first two drug steps in treating hyperkalemia are protect the heart, administer IV calcium gluconate or chloride, shift potassium into cells, give insulin plus glucose, and salbutamol nebulizers. They also help in that nebulization of salbutamol. The patient, however, does not even need step 1 because he does not have severe hyperkalemia or ECG changes of hyperkalemia. Hyponatremia. The cause of this hyponatremia is a result of TURP syndrome, transurethral resection of prostate. During the procedure, irrigation fluid enters systemic circulation through the exposed prostatic veins, which reduces the serum sodium. During the procedure, that is resection of prostate, the irrigation fluid enters systemic circulation through the exposed prostatic veins, which reduces the serum sodium level. The use of hypertonic saline, that is 3% normal saline, in the stem is rare. It needs to be used under senior supervision, and its use is usually for patients who are seizing or who are in a coma, who needs to rapidly raise the sodium levels. This can be followed with furosemide, especially if fluid overloaded, like in this case. So, about hyperkalemia, we already know the first two drug steps are: first, protect the heart, administer IV calcium gluconate or chloride; second, shift potassium into the cells, give IV insulin plus glucose and salbutamol nebulizers. That is the first thing. In hyperkalemia, treatment will be: first, protect the heart, IV calcium gluconate or chloride; second, shift potassium into the cells, IV insulin and glucose, and nebulization with salbutamol. It will also help in shifting of potassium into the cells. Second thing which we come across here is hyponatremia. It can result due to TERP syndrome. During procedure, irrigation fluid enters systemic circulation through exposed prostatic veins, which reduces serum sodium levels. Over 3% NS under supervision in patients who are seizing or in coma can be followed with in case of fluid overload. Used rarely. So this is what's important in hyponatremia. Here, hyponatremia has caused as a result of TERP syndrome, that is transurethral resection of prostate syndrome. During the procedure, the irrigation fluid entered into the systemic circulation through the exposed prostatic veins, due to which the serum sodium level reduced. Now, use of hypertonic saline, that is 3% normal saline, is very rare. It is used under very high senior supervision, and it is only used for patients who are in seizure or in coma, who are seizing or who are in a coma, who really need rapid raise in their sodium levels. And this can further be followed with furosemide, such antidiuretics, if there is fluid overload, like in this case. If patient is hyperkalemic with renal failure, dialysis is required. If there is no renal failure, then furosemide can be given. Patient in TERP syndrome may experience fits, probably due to hyponatremia, in which we have to give hypertonic saline. TERP syndrome can lead to hyponatremia. because the irrigation fluid get absorbed into the systemic circulation by prostatic veins and the serum sodium level decreases, so hyponatremia can cause fits. So we have to give, in TERP syndrome we have to give hypertonic saline plus furosemide. Since hyperkalemia is only moderate with no ECG changes, so here IV calcium gluconate is not needed. Hyperkalemia has to be severe with ECG changes, so as to give IV calcium gluconate. If no ECG changes are there, then we can just give furosemide. If hyperkalemia is there but no ECG changes are there, then we can just give furosemide. Okay, let's move on to next scenario. Here we have a 33-year-old patient on his third day in the ICU for COVID-19 pneumonitis. He is intubated, ventilated, FiO2 set to 0.1. Chest X-ray was performed. His ABG results are pH 7.2, PO2 6.8, PaCO2 7.9, bicarbonate 22, base excess -2. Chest X-ray is given. Patient is already intubated and ventilated. So in this case, we can carry out prone positioning of the patient. The answer to this question is prone positioning, also known as ventral decubitus. This is a case of patient with severe SARS-CoV-2 ARDS with refractory hypoxemia to a maximal FiO2. The chest X-ray would reveal bilateral diffuse infiltrates, also called bilateral whiteout appearance. Bilateral whiteout appearance. Prone positioning is an alveoli recruitment strategy which is used in severe ARDS. It is reserved for patients who have a PaO2 and FiO2 ratio, PF ratio of less than 150, despite optimal PEEP, that is positive and expiratory pressure, and optimal management. WHO recommends 12 to 16 hours per day of prone positioning. Inserting a chest tube is used to drain a significant pneumothorax or empyema, which is not seen here on the chest X-ray. We see infiltrates here. WHO, European, and NICE guidelines suggest that hydroxychloroquine and ivermectin play no role in SARS-CoV-2 management. ECMO is reserved for selected patients with complicated criteria and in this case of failure of all other alveoli recruitment strategies. In the case of failure of all other alveoli recruitment strategy, we believe the criteria for ECMO are beyond the scope of exam. Okay. There is no proof of superimposed bacterial infection, therefore no role of IV antibiotics in this case. So here the point is prone positioning. It is also called as ventral decubitus. Prone positioning or ventral decubitus is an alveoli recruitment strategy. Which is used in severe ARDS. It is reserved for the patients who have PF ratio of less than PF ratio of less than 150 despite optimal PEEP and optimal management. WHO recommends 12 to 16 hours per day of prone positioning. We know that if there is no proof of bacterial infection, there is no role of IV antibiotics. And NICE guidelines, European guidelines, and WHO guidelines all have suggested that hydroxychloroquine and ivermectin play no role in SARS-CoV-2 management. Inserting a chest tube is for draining pneumothorax or empyema, that is pyothorax, which is not the case here. As here we are seeing bilateral diffuse infiltrates, or also called as bilateral whiteout appearance. And ECMO is also ECMO or extracorporeal membrane oxygenation. ECMO is also reserved only for the patients with complicated criteria in case of failure of all other alveoli recruitment strategies. So it's also not to be chosen here. Here we will carry out prone positioning of the patient. Already ventilation has been tried. One extra point is bilateral diffuse filtrates bilateral whiteout appearance, also called as. So this is it for this session. I hope it was helpful, like it was for me. And see you next time. Take care.